Okay, brilliant. Thank you. Welcome everyone to October's governing body. We've got a short governing body in public with a couple of guests from DBH and FT. David Perdue, who's the Chief Nurse and Deputy Chief Officer, I believe is your title. Correct me if I'm wrong. And Marie Perdue, who's Director of Strategy, or something very similar. We're just going to rearrange the order a little bit. We start off as ever with questions from the public. Charlotte, have we had any questions from the public?
No, I haven't been sent any. Okay.
So we're going to move on to Bassetlaw Emergency Village because our colleagues have to get back off to DBHF2 FT. Shall we just do a quick round of introductions so you know everyone? David and Marie, is that okay?
Thank you.
Yep,
okay.
Thank you.
As you know, I'm Eric Kelly, GP in Retford and Chair of Bassetlaw CCG. I'm just going to go round the screen as it looks to me. Sue?
Hi, I'm Sue Sunderland. I'm a lay member for Audit and Governance.
Dr. Kumar?
Hi. Can you see me? I'm Dr. Kumar and governing body GP member. Thank you.
Idris?
Morning. You know me, but Idris Griffiths, Accountable Officer.
Victoria?
Victoria McGregor Riley, Deputy Chief Officer.
Sam?
Sam, Senior Lay Member for Primary Care Co-Commissioning, Application and Public Engagement.
Charlotte?
Charlotte Evans, Admin for the CCG.
Deepti?
I'm Deepti Alla, GP at Newgate Medical Group.
Kathy?
Hi, I'm Kathy Burke. I'm here on behalf of Nicola Ryan.
Hesh?
Hi, David and Marie. Heshan Arisena. We know each other. Clinical Director and GP. Thank you.
And Mr. Kumar, I hope you're not driving.
I've actually pulled up. It's Kumar Muthukumar from Secondary Care Doctor. I'm a gynecologist at Chesterfield Royal.
Good. Thank you.
Okay.
I can't see anyone else on my screen. Hopefully I haven't missed anyone else. Anyone out? So can I hand over to David, Marie?
Yes, thank you. I'll just attempt to share my screen. There's a few presentations here. Can you see those?
Yeah.
Yep. So first of all, thank you very much for inviting us this morning to talk to you about the Bassetlaw Emergency Village development. We have, as Eric said, our board this morning. So what we would suggest is that we just go through a few slides to give a bit of an overview and then have a little bit of time at the end for questions. So first of all, just to give a bit of context to the emergency village and the sort of case for change. So some time ago in 2019, we actually submitted a bid for capital to what was then the STP, which has become obviously the integrated care system, to really try and help us to address some of the issues we've got at Bassetlaw. And the main ones that we had were failure to comply with the CQC children's nursing ratios. And that was predominantly because we have our children's ward quite geographically separate to our emergency department, and it was very difficult for us to actually find the available nursing staff to be able to undertake that the amount of staffing that we needed to keep the service safe, and David will talk about that in more detail in his section. So we had to, in 2017, prior to the bid going in, we had to actually close overnight to inpatient admissions, and at that point we said we would consult on longer term plans for co-location. The second issue we've got is the size of the emergency department. So the current department is built really for 100 people a day. And we currently frequently see an average of 153 patients, and recently we actually got to 236. So we also don't really have the department designed in a way that really facilitates flow across the department. So the same day care isn't right next to the emergency department as it is in many of the modern facilities. So this was another issue that we were hoping to be able to address in this development. So looking at our same day emergency care facilities, and also to be able to address some of the backlog maintenance issues we've got in that area of the building. So in terms of the development principles, these are the principles that we've developed as a group. So first of all, it's about providing patient-focused, safe and sustainable adult and paediatric emergency services to meet the needs of our population. The design is clinically led and evidence-based, and we're looking to also consider what local developments there are in out of hospital care. And we want to be transparent, collaborative and inclusive in the approach that we're taking to the build. And our plans will need to be developed within the resources available. So the bid that was submitted was 17.6 million, and that is the envelope we'll need to remain in, even though we've clearly had some changes in terms of how we approach care as a result of COVID. So these are the investment objectives we've developed. I won't go through each of them for you, but I'll just leave them on there for you to have a read. So I think some of the key things in there around how we actually create a better environment, particularly how it's adaptable and flexible, and digitally enabled, how we can actually adapt in terms of different times of the day and different needs that we have at different points during the week as well. But also an environment that fosters that integrated working, so that we can make sure that we have the right facilities on there for partners that also in reach into the ED. So I'm not going to go through those in any more detail, and I'll pass on to David, who's going to talk through some of the clinical models.
Thank you. The next slide, please. So in terms of the work we've done so far, so there's been an awful lot of discussion with key stakeholders to ensure we've got the right people making some decisions. But in terms of the front door, there's obviously a mixture of new build and refurbishment. So what we want to do is to bring all kind of the main front door services together. So that's the assessment treatment centre and same day emergency care to the front door. So currently they're quite geographically spaced apart, and we actually haven't got an S deck. So that allows us to bring those two together. And then the work we've done mainly with kind of primary care homes is the effective front door streaming. So there's a number of models we've reviewed which need evaluating and costing. So I won't go through those, but they're the essence what we wanted to do and agree is that actually if you turned up for an emergency at your GP and you turned up for an emergency at the front door of the emergency department, you would have the same offer. And that's kind of what we want to get to. So obviously we're looking at the mental health facilities that we have. So we have to have a set mental health room and there's very specific guidance of what we need to have in that room, which we do have in the current emergency department. But we also need to look at actually the patient environment and how effective flow is in that design for people who come in, not just with a mental health illness, but people with learning difficulties, autism, dementia, to make it as kind of accessible to all as we can. So to support all that, obviously we need to look at the data that we've got and look at the modelling that will then inform the final designs of how it looks. So we have had a day out, a few days where we've got like some cardboard cutouts in the boardroom that people could look at in terms of the initial design. And there's been lots of feedback from that I'll go through in a moment. Next slide, please. So one of the main pieces of work around this is the children's services. So you'll know prior, if you lived through the pain that I did, the children's services prior to 2017. So towards the end of 2016, myself, Denise, whose name was completely forgotten, who was the chief nurse at the CCG, Nightingale. How can I forget? She was a chief nurse called Nightingale. Went to overview and scrutiny to discuss the issues we currently got in terms of nurse staffing. So there's some changes made to the number of children's nurses required in an emergency department that meant that we couldn't maintain having 2 children's nurses in the emergency department 24/7, plus keeping a ward open, which was geographically located, very isolated, the children's ward at Bassetlaw, keep them both fully staffed overnight. So in terms of that staffing challenge, we always have constant adverts out. We've obviously started rotating staff around both sites, and there's some work with the hosted network to look at the different models that we could do, but we have never been in a position where we've been able to staff the units so they can both reopen. So the model currently is, obviously we have a children's ambulatory unit which is open at 8 o'clock in the morning till 10 o'clock at night and accepts children up to 7 p.m. After that period of time, or if a child is unwell, children are transferred to either Doncaster or Sheffield Children's Hospital. We always had some pathways that children were transferred. So for surgery, emergency surgery, for any HDU or tertiary care model, those children were always transferred previously. But that's the model that we've had in place since 2017. So part of that was transport. So we have a specialised transport that starts at 4 o'clock in the afternoon until 2 a.m. in the morning, and that meets the demand in terms of when children attend either or are brought to the emergency department. So in terms of the impact of that, we have seen a slight reduction of children going into Bassetlaw for an emergency since. So there's a slight difference between before 2017 and after. Obviously, the overall length of stay has changed in terms of the children generally, in terms of their length of stay in hospital. So the average length of stay is now only 1.12 days. Feedback that we've had, we did a lot of work with families prior to the change. So we looked at all the families who used the service more than we used 6 times a year at that point, and myself and Andrea Bliss, who's the Divisional Director of Nursing for Children, spoke to all those families individually to understand their needs, why they came, and had individual plans for all of those. And we spoke to some of the children with long-term, parents of children with long-term conditions. So the feedback we generally had was positive. We haven't had many complaints, but the big thing around it is actually there was still like some facility on the Bassetlaw site which allows children who could have a short length of stay to stay overnight. So we're looking at a number of options in terms of the new model for children's services. Next slide, please. So far we've had an awful lot of stakeholder engagement with the plans. So all acute providers, with the primary care homes, with the hosted network. So we have a hosted level 3 network across SYB, and ourselves and Sheffield Children's Hospital are the ones who've got a level 3 hosted network or working towards it. IHP are the designers, health service designers, so they're working with us in terms of potential space, what we can use to make the best of the space and to fit in with the financial envelope. So there are a number of designs that have been put forward. As I say, there's a day where people, 2 days I think, where people could go and look at what that looked like, and people made comments and the design was altered accordingly. And we have a campaign company to support us with the engagement for the place. Just in terms of engaging with people working in the area, they're just some of the elements that people suggested we should do. So you'll have there in terms of the mental health, and what we need to do in terms around that friendly and the LD piece, looking at dedicated ambulance routes for patients and actually making the best use of the space. And there's outdoor space, so it will be a great asset to Bassetlaw as a place once it's completed. Just in terms of the success factors, I won't go through all those, but obviously there's a strategic fit and meets the business needs, which is clinical standards, constitutional standards, making access as easy as possible for the people of Bassetlaw and to address some health inequalities. And then we have to have, obviously, in terms of value for money, in terms of for the health economy, and then potential affordability and potential achievability. So they're our success factors. So I'll hand back to Marie.
Okay, thanks, David. I was just going to take people through the next steps for engagement. So we're currently developing the case for change. As you'll see, we sort of presented that at the beginning of the discussion. We're at the early stages of options development, where we are working with a number of people across different organisations, as well as obviously within DBTH. We have plans to discuss this with the Health Scrutiny Committee in November. We've also been in contact with the Clinical Senate to help us with the review of the options, and that's planned in for December, January this year. And also there'll be an NHS IE assurance process, which CCG obviously lead. That isn't us, but we will ensure that everything is available for that. And the involvement of stakeholders has been ongoing for quite some time. I was really hoping we might be able to have an artist's impression today to be able to show you what the build might look like. It's not quite at that point yet. So as soon as we do, we'll be happy to come back and obviously engage with the governing body as frequently as you would like us to. I'm hoping to get the outline business case ready for early 2022. So that's where we were hoping to finish, but clearly we're here for any questions, and I see that Tim has also joined us. Tim Noble, our Executive Medical Director, in case we have any clinical questions.
Thanks, Marie. Thanks, David, and welcome, Tim. I'll open up to the second two questions. Just a couple of quick things. You said the CCG will lead the NHS EI engagement. What happens if that goes past the end of March? Does that automatically go on to Nottinghamshire ICS to actually lead on behalf of place? And the second different question is, you said you had a budget cap of 17.6 million. I've currently got builders in my house just now, and they're a complete nightmare, and they keep telling me how expensive everything's getting. What's 17.6 million actually going to buy us in 3 years' time when we get building?
Yeah, would you like me to say? I'll take the one on the building cost, and it might be more appropriate for Victoria to perhaps take the other one, if that's okay, Eric. So in terms of the building question, we were concerned actually that there's no inflationary increase in that number. What we are looking at doing is looking at how much we can look at refurbishment as well as new build. So it will be a combination of both, but to still ensure we've got the appropriate flow within the build itself. We're also looking at ensuring we've got it right sized as well in the right places, so that we've got things that are co-located will mean we need less corridor space and things. So it's about really getting the design right. And I don't know if Victoria wants to answer the question around the NHS process.
Yeah, so yeah, thanks, Marie. Happy to. Eric, you'll be aware that the consultation is technically owned by the CCG because it's a commissioned pathway change, so we own the consultation in effect. NHS England have an assurance process, and that has multiple levels of assurance that we may be required to go through. What we're hoping is that based on the feedback from health scrutiny, it will be a level of assurance that can be managed at a regional level, not at a national level. So that would be our hope and our intention. But yes, the CCG at the moment is a statutory body. If this goes into an assurance process that goes into the following year, obviously that responsibility will be held by the ICB moving forward, but the statutory responsibility will still sit there.
Thank you, Victoria.
Can I just add to that point, Eric? Because Victoria mentioned the oversight of the region, and of course Bassetlaw will transfer into the Midlands region out of the North Eastern Yorkshire region. But for the purposes of Doncaster and Bassetlaw hospitals, it remains within the North Eastern Yorkshire region. So the oversight and assurance process for this capital work will remain in the North Eastern Yorks, although that commissioning lead responsibility will transfer into Nottinghamshire, as Victoria's described.
Thank you, Idris, Victoria, and Marie for answering those. Sue?
Yeah, mine was also linked to the sort of timelines for the approval process and what would happen if it slips, because it will make it quite complicated if it's into a different region. Is the timeline that it will have got as far as the PCBC by the end of March, or actually realistically are we looking for it to be in the new year? And although it's a relatively small scheme, I'm conscious that for obviously a much bigger scheme in Nottinghamshire, the CCG has set up quite, you know, sort of like an oversight group, a smaller group than the full governing body, and just wondered how. So this is a question to us as a CCG. We were planning to manage that assurance process to make sure we're linked in at the right times.
I'm happy to take the first part of that question, and Victoria might want to take the second. We have actually been doing a lot of work really in the background, because we were anticipating that this funding would be available sooner. So we had already started quite a lot of work around the case for change. So I am hoping it will be done within the timescale. But we clearly can't manage all of the external factors, so I guess that will depend on what the outcome and advice is from the Health Scrutiny Committee, and how they feel about the timescales we're suggesting for consultation. So I really would hope it would be done by that point. I think we've done quite a lot of engagement over time, so we're not at sort of a standing start with some of this work. It is quite a lot of it is already done in the background, and I don't know if Victoria wants to take the second half.
Yeah, happy to. So Sue, we already have established some informal meetings and get-togethers that I have with David, Marie, and a very small group of us. I think it's on a Wednesday morning or a very early morning meeting. But we've also now got structured engagement meetings that, as David mentioned, we brought in the campaign company to work with us on this in the way that we did with mental health, and we had a bit of a programme structure that happened. I think we were meeting every fortnight, and we'll be doing something very similar in terms of this as well. And part of this initial presentation was about bringing governing body into this wider conversation and updating you that work is being undertaken, but absolutely to hear from governing body about how they may want to be updated as we progress and move forward, really. But yeah, so those mechanisms are in place, Sue, both in a form of programme way from a DBTH perspective, but also from a CCG point of view.
Thanks.
Thank you. Any more questions or any questions for Tim around clinical pathways? Hession.
Hello, thank you. Just my questions around workforce. I think the presentation highlighted some of the challenges around workforce, and I wonder whether we've all considered options around potential opportunities to blend secondary care and community staff, looking at where illness sits, where footfall, where the vast majority of footfall sits. So, for example, if you take the Children and Young People's Initiative, I hope there's no doubt that the vast majority of children and young people are currently assessed in the community, primary care and community services. And trying to kind of move workforce between Doncaster and Bassetlaw might be challenging, but have you considered options about blending community staff, so community children's nurses, and then offering in reach into the urgent village potentially? Because I think the challenge has always been, I think it's going to be really difficult for any in the short term, at the very least, to try and stop people from turning up in A&E or in urgent care. But if they see the same faces in the community as well as in A&E, then over time we may be able to drag those patients out of the building into where their needs are probably better met. So I wonder whether there's been any conversations with certainly from the children's sort of nursing team, or even not healthcare trust around adult nursing team, community nursing team, in terms of having that sort of blended approach, if you like, where we can have a joined up workforce that moves with the patient and tries to drag them away from an acute setting.
So yes, we have, Hesh. So kind of we've met with the children's team and with Terry Hayes to look at actually what does that model look like. I think kind of that's a really important part. So the clinical work streams also looking at workforce, and that continues to adults as well in terms of actually what should we be providing within the emergency department with the kind of funding that we have and what's funding elsewhere to look at actually what's the best use of those resources. So yeah, they're absolutely being looked at.
Thank you. Kathy.
Yeah, thank you. I was just going to basically repeat what David said, saying that I know Terry's involved now. Victoria kindly invited Terry to the meetings, and it's something we've discussed for some time about a blended approach for particularly for children's services. So yeah, definitely that is a vision that we're supporting.
Great, thank you. Any other questions or comments? Dr. Noble.
Morning. Apologies, I had trouble getting started. I'd just like to say that this has a potential to be really exciting. This is an opportunity that we would have absolutely wished for back in 2012 when we were designing the ATC, to have this whole suite of emergency provision in one place, all seamlessly working together. The ability to blend your staff, the ability for your staff to support each other from not too far away, for patient flow to be really short-circuited through the investigation pathway, the observation pathway, and then on to further services. So I think this is a huge opportunity. For me, it would have been great a long time ago, but this is the time, and you know, I think we've got lots that we can do that will be really beneficial for Bassetlaw Hospital and the patients that we serve. So just a comment.
Thanks, Tim. I think we're all excited about this. We're all passionate about healthcare in Bassetlaw, which is why we're all on the governing body here, and we want to see improvements for our patients. And as Heshen said, we want to keep our patients out of your building as much as we possibly can as well.
Sure.
I'm conscious of time, and I know you guys have got your Trust Medical Board or something similar. As there's no further questions, thank you very much for giving up valuable time this morning to come and update the governing body, and we'll look forward to having updates either from yourself or via Victoria in the future. If you've got any further significant updates, you're more than welcome to join any of our governing bodies to update us. Thank you.
Thanks very much, Eric. Thanks
very much. Thank you. Bye.
Thank you.
Bye.
Right, that's kind of colleagues from DBHFT to come and join us. I'll just get back to the agenda itself. We've got apologies from Louise Lester and Nicola Ryan. Obviously, we've got Mrs. Burke joining us in Nicola's space. Have we heard anything from, I noticed Lindsay Britton isn't here. Charlotte, any apologies or anything from Lindsay this morning?
No, she's not sent them to me. I'll note her apology.
Okay, thank you. Any updates on declarations of interest, Dr. Kumar?
Yes, hi, Eric. I'm sure you'd have heard that I've taken the clinical director role for Larwood and Bottery, and I would like that to be added on the conflicts register, please.
Thank you, Dr. Kumar. In a similar vein, the clinical director for Retford and Villages has stood down. So as a temporary measure until we get a permanent solution, I've agreed to take over as clinical director in the short term until we find a solution for Retford and Villages. So could that be added to the register as well, Charlotte?
Will do.
Thank you very much. We are core at quality and patient safety update, Mrs. Burke.
Okay, thank you very much. I'll just highlight some things, but please ask me if there's anything else you want further information on, and I'll either provide it today or later. So first of all, we're talking about the integration work that's taking place for the CCGs. So we're still very much involved with the South Yorkshire and Bassetlaw transformational work, but also with Nottinghamshire and Nottingham City as well. So we're having Nicola's involved in regular meetings with those. We've had another one this morning with South Yorkshire about planning quality and governance and structure around quality. We're going to ensure that as we move forward and align ourselves more and more with Nottingham and Nottingham City, that we do have still a link into South Yorkshire, because obviously, just as Idris has said, we've got the Acute Trust and Sheffield and other areas of work that we need to work together on. We're getting more and more well, we seem to get more and more requirements from NHS England and improvement about assurances, which is, I think, is to do with the transition work. And one of them has been around our readiness and preparedness for the liberty protection safeguardings that are still saying that they're going to be coming in place on the 1st of April. So we have done a response to that. We've completed the audit, and the audit will be changing every quarter. So they won't be auditing the same criteria. So we've responded to that. We know where we are in relation to the numbers as of that time for deprivation of liberty that we'd expect to transfer into an LPS process. And we've done some preparedness work already, such as when we had the BEST in February, which had really as a concentration on frontline practitioners being really up to date with their responsibilities around the Mental Capacity Act and assessing capacity. There's been an independent report and review on the Children and Young People Services in Notts Healthcare Trust. This has highlighted some concerns and they are being taken forward. There is an action plan around that, and they're being addressed through Notts Healthcare Trust, and they're being monitored through Nottingham and Nottingham CCG Quality Assurance Group that Bassetlaw is a member of, Bassetlaw CCG. We were fortunate to go to the Health Inequalities Forum. Thank you, Victoria, for inviting us there. And we had to focus on children and young people. And this was raised through our maternity and children young people's assurance group, as there'd been a number of reports really focusing on the vulnerabilities of children and how they increase in areas that are more deprived. And so we took that information to the Health Inequalities Group. It was supported with Public Health and our other partners, DBTH, etc. And there was an agreement from the group that we'd like to have a focus on the theme of obesity. So to see where we're at with obesity, if there's a lot of work going on, but that's what the group felt would be an area we could look at. So that work needs to progress. Continual healthcare is basically up to date with the continual healthcare requirements. Fast track numbers remain around about 60 patients. There are, it doesn't say in this paper, but there are, and I think you'll be aware of a lot of pressures around home care providers. So that is something that our CHC team is dealing with on a and balancing the packages of care. Those are the numbers of the PHBs. Nothing particular to report on them. That's just a statistical number. The care home work, we've had a closure of Clumber Court. Well, it's closing. We've just got a few people left in Clumber Court, and the CCG has been supporting the moves into safe placements for those patients. Obviously, the moves that have moved in, those who've moved into other nursing homes and residential homes in Bassetlaw means that our numbers have been affected for vacancies across Bassetlaw. And also we've been working very closely with the care homes and nursing homes in relation to the vaccination programme, because by the 11th of November, the expectation is that all care workers in the homes have been doubly vaccinated. That is reported through QAPs. Learning disability and autism, our learning disability liaison nurse is working. As you know, we had a different model for providing that, which we introduced fairly recently. It's been really successful working with Doncaster and Bassetlaw teaching hospitals, progressing the acute trust LD new strategy, and delivering training, but also focus on individual patients' needs and supporting their needs as they're going in and out of hospital. There's been a focus on bowel screening project, and that is on track. It's developed really well. So the LD liaison nurse has been working with primary care to develop that. And we just have 4 individuals in inpatient settings at the moment with LD or autism. The SEND quality issues have been taken to QAPs, and we've got some concerns around SEND at the moment. So there's pressures on educational psychology work who lead on SEND on educational healthcare plans for the multi-agency system. And they are now struggling to meet the requirements. The educational healthcare and plan annual reviews, there's a backlog which is concerning for a number of reasons. Obviously the number on the backlog and the timeliness in which the CCG was informed of this. We know that there's not enough school placements available for children who require special needs school placements. From a partnerships perspective, all these areas are being worked on and they are developing a risk plan around them. That's the end of the report. If there's any questions or queries from anyone.
Thank you, Kathy, for the update. Just jumping back to care homes and staff vaccination for a second. Do we know how many of our care home staff may not be doubly vaccinated by the 11th of November, and does that pose a risk to our care home residents?
Yeah, we do know. We have got a list, and I can't remember it off the top of my head exactly what that is because it's a changing list as well. The full list went to QAPs. There's not a lot, but obviously those that aren't doubly vaccinated won't be able to provide the care. So we can get those numbers if you want them putting into the minutes and circulating, but obviously their HR departments are working to address this as well.
Okay. Thanks, Kathy. Idris?
Yeah, just on that last point, it is a very small minority of staff. I know, sort of early on in the pandemic with flu vaccinations, there was concerns that there was very low take-up, and that isn't the case. So obviously there are people who still haven't had both vaccines working in the care sector, and we very much encourage them to do that, including the 3rd booster when that time is up. But they are small numbers. But I just wanted to pick up on another point, and Kathy mentioned about learning disabilities, and I just wanted to commend the work on that. You know that we're sort of record-breaking with learning disability checks through primary care. The new arrangement with directly employing the nurse working on learning disabilities is really improving that continuity of sort of admission into hospital and discharge out in the care, and support for people with learning disabilities throughout. And we've seen that in the success of things like the vaccination programme, for example, coming back to that theme, where our take-up with people with learning disabilities far exceeds many other areas, and I think it's about that continuity of contacts and the trust, sort of that's built up, as well as the very high levels of care and support that are provided. So I just wanted to highlight that. Thanks.
Thank you.
Thanks, Idris. Hessian?
Thank you. Just a couple of things, really. The first one is the last time I saw the care home data was probably about 2 months ago or so, and at the time I vaguely recall the rate of not being vaccinated was around about 15%, something like that. So I wonder whether it's worthwhile just double checking. This was probably just prior to it being announced that you will no longer be able to work if you've not been double vaccinated. So I would hope that the rates have improved, but it would be helpful to have a look at those figures, because in any care sector, regardless of what that care sector is, if suddenly 10% of your workforce is no longer able to work, it'll have a destabilizing effect. So if it's possible, I think Andrew had those details. I think he came to primary care committee, if I remember correctly,
We've got
including hotspots.
Yes, sorry, Hession. We've got those details. Rachel's been working very, very closely with all the homes. She's been tirelessly working with them. She's got the numbers. She's checking the numbers regularly, and it's done in partnership with the local authority. I don't think it will be 15%. I agree with Idris. It's very small numbers, but I'll definitely check the most up-to-date position, because it's probably changed from QAPs. And then I can. Who would you like me to forward that to?
If I think where I saw it last was primary care committee, the data. So if that's the forum plus QAPs, I think that would be okay. Yeah. Or I don't know, but
it was on QAPs. It's on QAPs every
if
month.
If it's any help, the position that was reported to QAPs at the beginning of this month was that 42 of the 43 homes were online to have over 90% of staff fully vaccinated by the deadline. So it has improved significantly. Okay. And Terry is on top of, she knows for each individual home what the situation is, and has been working with them. So there are a few minor risks, but they're relatively small and hopefully manageable. The danger will always be if staff move, but at least it had improved significantly from when you last saw it, Hesh.
Thank you. I suppose the other point to make is the government have updated their exemption criteria. So, and again, considering it's a young workforce and predominantly female workforce in the care sector, pregnancy is one of the big things that people had concerns about. And if they're currently pregnant, I think they can apply for an exemption in relation to vaccination through a process. So again, as long as the care sector is aware of that, that might help to mitigate against some of the risks. My final point was around learning disability. So you know, again, I'm fully supportive of the employed staff supporting the uptake of learning disability reviews and improving kind of help for that cohort of the population. When I last spoke to Nicola, one thing that we were yet to define is what additional support those members of staff can offer primary care in relation to increasing uptake of the learning disability reviews. And taking on Idris's point, considering we are already high performers in that area, I think primary care have probably got very good relationships with their learning disability cohort, and therefore the ones who are resistant to engagement are probably going to require additional support, more so than what we initially anticipate. So I wonder whether within that role, whether we could try and define what additional support that team could offer patients and primary care in terms of improving their performance even further in terms of engaging with primary care and accessing healthcare. Because I think the last time I had a conversation, Nicola said it was work in progress. So whether we could define that a little bit more, that would be really helpful. Thank you.
Yep, we'll look at that.
Yeah. Thanks, Hesh. Thanks, Kathy and Sue. Idris?
So yeah, I've had a quick look at the figures as well. Last week, care home residents and staff, and it's difficult sometimes to disaggregate, 96% had had the first jab, 93% both jabs. So I think one of the things, and one of the reasons I sort of highlighted this is, I think sometimes those people who are refusing or reluctant to have the vaccine seem to think that they form a larger group than they really do. And they are a small minority, and I think hopefully, a greater recognition of that is an encouragement for people to come forward and get the vaccine. And we have what we call the evergreen offer. So those people who've been previously worried about getting the vaccine haven't had it yet, they can still take that up, and they can have their first dose whenever they like, sort of if they've decided to. And just on the pregnant women thing, and again, there's a danger of mixed messages in there in terms of an exemption versus whether there is sort of any known risk, and there is no known risk. And in fact, quite the opposite. Pregnant women are disproportionately represented in those that are acutely admitted due to COVID. So actually there is a strong indication that people who are pregnant or thinking getting pregnant should have the vaccine, because that's by far the safest thing for them to do. I just wanted to emphasise that.
Yes, can I just confirm that we've had a couple of pregnant women working in care homes who we have put in contact with maternity services to get extra support for their vaccinations, but that was a number of months ago now. So if we do become aware of it, we do get the midwifery services involved to support these mums.
Thanks, Kathy. Thanks, Idris. And thank you for the update. Moving on, next on the agenda is Better Mental Health for Bassetlaw update. Victoria, can I hand over to you?
Thank you, Eric. So, so Idris, you've got your hand up at this point as well. Do you want to just come in?
Yeah, I just wanted to jump in at the beginning of this item, if I may, because I attended in person the Health Scrutiny Committee last week, and I just wanted governing body to be clear about the discussion that was had last week in that committee and what their conclusion was. And it'll give, I think, Victoria an opportunity to address some of the concerns that they raised as well when she does the main presentation. So, as you will recall, governing body has decided in principle to support the change in the mental health provision alongside our £4 million worth of investment in Bassetlaw services for mental health. But we said that we would bring back the transport plan, which is Victoria is doing. And a similar conversation away was had with the Health Scrutiny Committee, not that they supported it previously either, but they did want to see the transport plan. And that's what I presented back to them sort of last week. I think the short version of the outcome of that is that a number of members of the committee, including the chair, had expressed their view that they wanted and had expected to see a specific transport offer, such as a shuttle bus. I'm sure Victoria will be able to sort of comment on the pros and cons of different options. And they decided that they could not support the move, and that they thought the transport plan was not as they had expected, and didn't meet, sort of the in their view, sort of the needs of patients. But we'll come back to that. So it's just the governing body are aware that the Health Scrutiny Committee did not support this move. It is the governing body's decision. But it's important that we listen to all different stakeholders and different parties whilst we make that final decision, particularly around this transport plan. So I'll hand back to Victoria. Thanks.
Thanks, Idris. So my suggestion is that I'm going to go through some of the most salient points, I think, in the paper that colleagues have received. I'll then go into the travel plan in a little bit more detail, which is appendices to this document, and then we'll go through a Q&A session after that, if that's okay. But obviously, if at any point people want to interject, please feel free to do so, and I'll rely on Eric to make sure that I see that. So going through the paper then, and the most salient points, obviously governing body had the discussion in July about the proposal to transfer services from inpatient bed state at Bassetlaw Hospital into Millbrook and Sherwood. There was concern expressed by governing body, particularly in relation to the travel implications for patients, but mainly for their visitors, their carers who wish to see them in an inpatient setting. There was also consideration given to an option around crash beds for patients, and also opportunities around increased support for virtual visiting to support people to maintain connected to their patient, their families and carers, etc. In order to progress that conversation, we established a task and finish group, and thank you to Sam for supporting that as well from a lay representative perspective from governing body, to make sure the governing body colleagues were engaged in the process. That task and finish group comprised of a number of members as well, also from Notts Healthcare as well as from the CCG, people who were involved in travel arrangements and support and finance, as well as mental health. That task group also undertook a range of opportunities to engage with our wider community, but specifically those likely to be most impacted by the change. And obviously that task and finish group and engagement piece of work sat on top of already the very extensive engagement that we'd already undertaken since the last year, which also, as Idris has indicated, involved a number of presentations to Health Scrutiny in that journey, starting from last September. So building on that extensive engagement already, and undertaking some desktop review of the responses we'd already received from that process, as well as this further engagement, and more details of that is obviously provided in the paper. We developed the travel plan and the response that we're now going to consider here. During that 3-week period, you'll see that we covered, I think it was over 50 odd individuals that we actually spoke to. And most importantly, that it included people who are current service users, as well as recently past service users. So people that we felt very much represented the voice of those most impacted. I just think it's really important that we bring that out, as well as a wider range of patients and patient representatives. There's also 27 patients that we did on telephone interviews that gave that broader breadth of understanding and awareness in the engagement. The key questions that we asked people were around what kind of principles do we need to base the travel plan on? What support would people find most helpful? And importantly, what criteria, if any, should be applied to access that support? What came back was consensus around 3 key themes. We've described these as summary of key principles. They were maintain fairness and equity for all patients, carers and families, and that included across those from a mental health perspective, but also a physical health needs perspective. So there was very much a view that all patients and carers and families should have equal access to support, and that they didn't want to create inequity of access by offering a higher level or an enhanced level of support for certain patients and families and not others. So that really did come through in the conversations that we had. The other key theme was about whatever we're going to do, can we please make it simple and easy to understand and not overly bureaucratic? And that also came not from patients and carers, but also from staff involved in the consultation that we undertook, the engagement that we undertook. Because of the application, it needed to be something that they could explain that was relatively easy and simple as well. So that came from different perspectives. And also, if we're going to apply any criteria, that needed to be flexible, it needed to be adaptive, and it absolutely needed to speak to the individual circumstances of each patient and their visitors. So this was a very, clear set of messages that were coming through from the engagement, and gave us considerable food for thought in terms of how do we apply those principles and make sure that we meet the expectations of people. So in terms of those key findings, therefore, we absolutely heard that there was a good level of support for individual travel plans and the ability to have individual bespoke travel plan arrangements. There wasn't a one-size-fits-all approach that would sit comfortably with the broad spectrum of people that we spoke with. There was consensus that patients should be given autonomy in terms of how they travel to visit their relative or their significant other whilst an inpatient. And that needed to, again, speak to individual circumstances around visitors with dementia and older visitors and frail visitors, but also visitors who had family commitments, childcare arrangements, working arrangements, etc. So there's a whole broad spectrum, again, of need. There was very clear feedback that the support needed wasn't just financial, and actually the vast majority of people felt that the non-financial support was as important, if not more important, to support carers. They would very much value a range of information provided to them around what different forms of transport were available, what other facilities were local to Sherwood Oaks and Millbrook, where if they were coming to see visitors during the day, they could take the patient with them to go to a local cafe, for example, and just engage with them in a different way within the local vicinity. So those kinds of issues really came out, and that information needed to be provided both as a hard copy so that people could go through it at their leisure, but also electronically so they could access it in a remote and virtual way. So that really came out as quite an important aspect of any travel plan arrangements. There are also some consideration, particularly from carers groups, around how they could support buddying up. And we got quite interested in that as an opportunity, maybe into the future, around providing peer support amongst the community of carers and visitors, using peer support mechanisms and carer groups to enable our carers to have more support as they travel to and from seeing their inpatients, their relatives and loved ones. There was no consensus, as indicated, about the criteria, and most people were fairly silent on that. They felt that was a very difficult topic. They didn't really generally want to engage in that, and they felt that that was up to us to try and put some parameters around that. But generally speaking, people didn't want to engage in the establishment of criteria because they recognised that it's very tricky. There was a clear concern, however, as I've mentioned, about any additional financial support to patient visitors could create inequality, and they were concerned about that. The interviewees, including staff, also raised concerns that in the long term there may be perceived, as well as actual unfairness, between patients attending Millbrook and Sherwood from Bassetlaw as opposed to those inpatients attending from other parts of the county. And as we've always said throughout this process, we are trying to take a more wider perspective of these arrangements, improving overall access for all patients, not just Bassetlaw patients, but for the whole county of patients that require these services. And we recognise for the vast majority of patients currently using B1 and B2, the arrangements moving to Mansfield will greatly enhance their access. It will make these services closer to home for them. And we've always agreed as a governing body that a wider perspective was really important to us. And so in recognition of that, the people that we spoke to were really clear that they were concerned that by offering us a different level of support to Bassetlaw patients only, we were creating some complexity for the staff, particularly in having those conversations. And there would be perceived disparity between patients and visitors from Bassetlaw as opposed to other county residents. So there was also a concern that, you know, there was acknowledgement that it's specialist mental health support that's been provided in inpatient beds, but the question came back to us, well, we're accessing specialist services elsewhere, for example, in STH for cancer care in Weston Park, but we don't have access to additional support, financial or otherwise, to access that. So it did keep coming up. It was also noted and brought out that the CCG does not have a statutory responsibility for providing funding for visitors. It isn't part of our national expectations. And obviously we're all fully aware already of the accessibility for patient transport services already provided through patient transport services. And there's some information about that in a bit more detail in the paper, but most of the colleagues on this meeting will already be fully aware of those. And in terms of access for patients, obviously the expectation is that that will be provided through patient transport services, so that won't change. So patients isn't the focus for this transport policy, it is visitors. And the other just key thing to mention is that there was acknowledgement again from the people we spoke with that it was a challenging situation, given the fact that they were aware that there is already a high demand for NHS resources, and that in providing additional funding for this particular cohort of visitors, we were therefore manoeuvring money through the system, and that could have implications for investment in other areas. So there was just an acknowledgement of that as a point of principle. As part of this, we also just did look at the figures again in terms of likelihood of impact of volume of patients. And just for noting, the latest data did suggest that there were 65 patients that accessed B1 and B2 wards within the latest 12-month period that we've got data for. So I'm just giving you an up-to-date position on the volume there. So overall then, the travel plan for visitors, as you can see in Appendix 1, indicates support in two key forms. One is non-financial support in the form of a comprehensive visitor guide that can be offered to all patients and visitors, both virtually and hard copy, and that will be maintained by Notts Healthcare. And the other support is around financial support that will be in the form of a personal allowance. I'll go into those in a bit more detail in a second. The overall estimate of cost implication for the CCG at this point, based on working assumptions that we gleaned from the engagement, would be in the region of about 7,000. But as I've indicated in the paper, should those working assumptions prove to be invalid, then obviously there could be greater or less cost impact for us. But we are in discussions with Notts Healthcare at the moment to talk about how we share the risk around those cost implications and to make sure that that cost can be mitigated as much as possible between both organisations. There is a proposed timeline for these changes should governing body make the final decision to progress as indicated. And obviously there are key milestones as part of that proposed changes, which will include the development of the non-financial support, as well as further engagement and communications with our wider stakeholder community, not least of which are going to be our GP practices, as well as our patients and our carers, to make them aware of the proposed changes and when they will come into place. In terms of supporting staff and workforce transition, we still wanted to make sure that governing body were aware that staff affected have been spoken to, that arrangements have been put in place to support those staff to either stay working with Notts Healthcare in Bassetlaw and or at the alternative sites. And those individual conversations have now concluded, I believe, to people's satisfaction. The consideration of the crisis beds or the hot beds or whatever terminology we want to use, again, that was considered and has been considered with Notts Healthcare colleagues as part of the production of this paper. Current indications are that only 7 patients have actually used this kind of provision since 2019. So again, the volume is extremely low, and we've currently got our services provided by Turning Point in Nottingham. And indeed, we are actually one of the lowest uptakes of that kind of service in the Nottinghamshire area. And we're also acutely aware that the impact of the over 4 million investment that we're making will also support more people to be supported, to be maintained and supported in the home and community environment. And indeed, for those in crisis, we all have as well invested, as we're all aware, through the intensive community mental health service provision, through the intensive home treatment team and the crisis resolution home treatment team as well. So we believe that in reflection, those services are there and will in fact be bolstered further to support that need. So we don't recommend at the moment that we do invest further in any crash beds, but obviously that's a conversation we can have in governing body. So in conclusion then, what we are proposing is that we progress with the relocation as previously recommended, that we develop the non-financial and the financial support mechanisms as outlined in Appendix 1. That we also, importantly, I think, review the travel plan in a 2-year period. And as indicated in the paper, that is because not only do we need to make sure that this maintains and sustains the right approach for the visitors and carers, but it's also to reflect the national consultation that's currently been undertaken, which will be concluded in the new year. And seen as patient travel arrangements will move to the ICEB, we also need to make sure that we don't, again, exacerbate or create inequity or unfairness across our wider Nottinghamshire community. So that needs to be reviewed to make sure that that maintains that sense of fairness and equity. Obviously, note the potential financial risk as outlined based on the working assumptions that have been, again, outlined as part of the appendices, and therefore ultimately to provide a final decision by governing body as to the relocation of specialist mental health inpatient beds from Bassetlaw to Millbrook and Sherwood Oaks. So I'm going to stop there, Eric, if that's okay, and if people would therefore like to ask any further questions, I'll take them at that point.
Thank you, Victoria, for that gallop through things. I just noticed one slight sort of typo, type is probably the wrong word, in page 6, where it says from the 1st of April to the 26th of May, BCCG and Notts Healthcare to communicate to all GP practices in Bassetlaw. Obviously, BCCG won't be able to do that.
Yeah, that'll be the place responsibility, Eric, at that point, on behalf of the ICB.
Thank you. Hessian?
Thank you. First of all, thank you very much. I thought the transport plan was pretty comprehensive and covered all aspects, not only just looking at mental health, but the potential inequity that might be introducing to physical health as a result of treating cohorts differently. I wonder, the other thing I did think about when I was reading this was have colleagues taken into account, not CCG per se, but other colleagues at Health Overview, Scrutiny and Overview Committee around the concept of attendance allowance. Lots of carers or patients can request attendance allowance in terms of supporting transport as well. That could also supplement some of the transport kind of allowances, if you like. And did Health Scrutiny Committee have any alternative suggestions to make that would meet their expectations? That's sort of one question. So I'll ask that first, and I'll move on to the crash bed question in a moment.
Shall I come back on the health scrutiny?
Yeah.
So the main alternative suggestion made by a number of members of the committee, including the chair, was a shuttle bus. So obviously a shuttle bus would have a timetable to it. At one point it was suggested perhaps that shuttle bus would go twice a day, for example. And I think the issues for us there is to actually have a shuttle bus available to do the number of journeys for the number of people that we're transporting would be disproportionately expensive and wouldn't meet the needs of what the public, the patients and carers had actually said, which is they wanted something that was very bespoke and flexible because different people will have different needs. And a shuttle bus that goes at 1 p.m. on a Tuesday isn't necessarily going to meet sort of people's needs, and but that was the main sort of issue. I'll let you make your. Well, Victoria wants to come back as well on the other points.
Just on that, I just think it's where we did discuss a range and variety of different transport options. We talked about taxis, we talked about community bus services, we talked about national bus services, we talked about train services. We went through the logistics of people using those different transport routes. We've looked at all the prices, all the season tickets. We've looked at the cost of taxi services. We've looked at all of them, all the different modes of transport you can possibly imagine. We've spoken to community transport and bus providers. We did a whole range of exploration of different travel modes. And we kept coming back to what people were actually telling us. And so in one of the conversations, there was somebody who had 2 children and, for example, a shuttle bus. How is that going to be helpful for me? Because I've got to get the 2 kids up to Bassetlaw Hospital, get the shuttle bus for the 2 kids down into Mansfield, arrange for the transport, then to come back up again. How is that any more helpful to me at all? So we were listening to what people were saying to us. And we felt, therefore, the solution was really allowing the individuals to choose the mechanism and mode of transport that best met their needs. We had people who had dementia, you know, and they were trying, you know, a shuttle bus is really confusing. I'm not going to get the timetable. I'd much prefer the community transport because they pick me up, they know me, you know. So we try to keep the opportunity for people to design their own solutions that best met their needs. Shuttle buses were considered, but again, in terms of cost as well, we looked into the cost of it, and it was exorbitant for the potential amount of travel and use it was going to receive. It would be sat there the vast majority of the time because people weren't prepared to use it. So it was discounted as an option. So I just want to convey there was a broad range of work and consideration that went into the different modes of transport, and it came back to a really simple solution. Let people design what's best for them. And let's support them to access funding to enable them to do that.
Can I say incredibly sensible, and I fully support that. So from a transport perspective, because I can't think of an alternative way of doing this at all, really. My second question is around the concept of crisis provision, and the paper seems to indicate that the community crisis team will be able to manage the vast majority based on the premise that only 7 people actually required an inpatient assessment for crisis, if you like. Has NHT or the CCG looked at the number of patients presenting to A&E as part of a mental health crisis? And importantly, how many people are presenting to A&E repeatedly as a result of a mental health crisis? And what is that figure in comparison to that 7 who ended up being admitted? So I suppose my logic is you can't discount a service based on arbitrary admission thresholds set by the provider if it's not really addressing the needs of the population potentially. So for me, I think having the concept of community, great, the vast majority can be managed in the community. There will be a cohort of patients who are repeatedly accessing healthcare from other settings who would benefit from a different place of safety that's not their home, that could deal with their mental health crisis. That is not an acute A&E setting with all the ramifications that follow as a result. So I'm still keen, whether you want to call it a crisis bed, whether you want to call it a special place within the emergency care village, you name it, I don't mind, but I think there needs to be, from my perspective, a halfway house between community therapy and admission to a bespoke unit in Mansfield. Thank you.
Thanks, Hesh. Just to come back, we did. The numbers are very, very small, but we did, and we have had that conversation, as David alluded to in the earlier presentation already, about the emergency village offering that as a safer space. We've already talked about that, is developing it. So I think between the two provision, both in terms of what we've already invested in and that, I think that will support those needs, Hesh.
In which case, may I suggest we redefine the criteria, the threshold for accessing a different form of provision other than home care for crisis prevention. Do you see what I mean? Because at the moment we have home and admitting to a psychiatric ward. If we have another avenue, we need to rebalance that kind of threshold at which point they can access that support. Because otherwise you'll get the same concept where they're not really suitable for Mansfield. They're probably not going to be managed appropriately to their expectations in the community, and they'll keep bouncing in and out of hospital A&E departments.
Yeah, we can absolutely do that, Hesh. Yeah.
And it's worth just being clear that the crisis intervention support for A&E is not being affected. So that will always be there.
Yeah.
And the opportunity with the emergency care village to create a really appropriate space for caring for people who, you know, sort of need that input from the crisis intervention team, you know, it is a good opportunity. Obviously, if somebody is at the level where they need an admission, and particularly if they need to be sectioned because they're a risk to others or themselves, then you're talking about specialist care, and that's a different matter. Obviously, the new facilities will be able to provide that far better than what we currently have.
Thank you. Deepti, then Sam, then Sue.
Yeah, I think I just wanted to ask about the transport issues really, because I think the plan is great, but does it take into consideration the families really? Because considering these people have moved not much in their entire lifetime out of the region they live in, and if they have to have access for family, then would family transportation be considered if they were hospitalized for prolonged periods of time? And that would pose an issue whether that had been considered really in the future. But I have an example of a patient recently that had been admitted to Mansfield area. We are looking at hospitalization for periods of time, but when they find rehab for these patients, because most of them tend to be people with less family connections or people who have addictions or other issues, and then they rehouse them in areas outside the area where they come from, which is Worksop. How is it getting managed? Because those patients then slip through the net. They are still registered with the local GP practice, because by the nature of their illness, they refuse to then re-register with the local services. I have 2 examples of them which I can easily fish out and send back to you. Are the wider settings taken into consideration? Because we're talking at smaller numbers that need hospitalization, let's say 7. A couple of, which means they are definitely high risk. And how are we, is there any provision in the plan, which I haven't looked at really, how they are looking at, because once they get discharged from the ward, they just need to be rehoused somewhere. And are these issues taken into consideration really, or are we making the issues worse?
Do you want me to take that, Eric?
Yes, please.
Okay. So Deepti, we've got to remember the scope of this engagement is around the relocation of the inpatient beds, and the scope of the travel plan is around patient and carer visitors for those receiving inpatient care. So we haven't extended the scope of our review in terms of rehabilitation and care, which evidently we can pick up any issues and concerns that we've got around that. But those are existing pathways of care, and that would happen irrespective of the inpatient relocation, because that is what happens to those patients along current care pathways. So that's not a change, that is the way that we manage rehab. So more than happy to pick that up as a separate issue of concern if that's been raised, but I must say that's the first time I've heard of it. But absolutely happy to pick that up if we need to reconsider rehabilitation, support and care for patients.
Thanks, Victoria. Sam?
Yeah, it was just to support Victoria really, having attended the transport task and finish, that the group have listened to feedback. They have engaged with a wide array of people, and debate's been constructive and well considered at the task and finish group. So it was just to give assurance to the governing body on that.
Thanks, Sam. Well, I think as a governing body, we are reassured and assured. Sue?
Yeah, I suppose my concern, I think for what it is, it's comprehensive, and I can see where it's come from. I suppose my underlying concern is how we stop this setting a precedence, and why this is fair for everybody else, given the pressure on health resources. I'm very sympathetic to the needs of these people, but then I'd be equally sympathetic to somebody who's got to traipse off to Sheffield or Leeds or wherever for specialist healthcare. And part of the business case for moving these beds is that they will be getting better care and in a better surrounding. So there is a clinical reason for supporting the move of the beds. I suppose I am struggling with the principle of why we fund this transport and how it's fair to everybody else. And I'm not sure I was convinced that we'd fully address that in the paper as to how we don't set a precedent.
Victoria, do you want to come back?
Yeah. I recognise that, Sue, and as I've indicated, it's something that did come up as part of the engagement. I think what we try to do, Sue, is strike a balance between the fact that we have changed the care pathway. It does mean that for some members of our community, there will be an additional burden of travel arrangements, both for the patients, which we cater for through patient transport services, but also for carers and families. When we've got families who are travelling, quite a distance, particularly from the northern area of Bassetlaw, a high area of rurality and complexity of the travel arrangements, that does create an additional burden for them. We're also keen that we hear the views of our wider partners, including Health Scrutiny, and that was very much a concern that they had around creating inequity of access because we've moved services. So I think what we've tried to do is balance the concerns from all our stakeholders as much as we're able to do. And I think at the end of the day on this one, we've been very clear that this is, if approved by governing body, on a basis of absolute exceptionality. This is not setting a precedent for other travel arrangements for other patient cohorts. And it is an arrangement that will be reviewed within that 2-year period and will not need to be consistent with arrangements that will be provided for us on a national perspective anyway through the national consultation process. So, and I think if things materially change before then, obviously it will be beholden on us to review it before then if we have to. So I think what we're trying to do, Sue, is marry those challenges. If we have changed the pathway, it is going to create an additional burden for some of our most disadvantaged members of our communities. We do not want to see an inequity of access and poorer outcomes, health outcomes, for people who are particularly vulnerable at this moment in time. We know that visiting, particularly for mental health services, is such an important part of recovery. It really does aid overall recovery rates for those patients. So in terms of cost benefit, it is in our interest in terms of cost benefit as well as patient outcome to support carers to visit. So I think for all those reasons, Sue, we're seeing this on the basis of exceptionality for those multiple reasons.
Do we in that case need to have some sort of means testing or whatever rather than making it, because as I read it, it is accessible to anybody in that circumstance, whether, I mean, you're encouraging people to continue to use their own means if they have it, but actually my reading of this would not have stopped anybody who could easily afford to do it themselves from doing that. And I suppose so. I am very sympathetic to those who really will struggle to do this, but I suppose I'm just conscious that as it currently stands, it is open to anybody who fits the criteria, because the criteria doesn't include anything around testing people's ability to do it themselves.
Yeah, just in terms of that, we're trying to respond to the specific requests, particularly around staff and health, the peer support workers and NHS, not healthcare staff, about the complexity of the process for doing it. And we started to get into really convoluted, are they on universal credit? If they're not on universal credit, are they on other means tested benefits have they got? So it started to get very complicated in terms of the machinery, which when we look at the volume of the potential impact of who might apply, it started to get disproportionate. So there's kind of, again, a cost benefit analysis about the amount of time and energy, financial and administrative input into administering the scheme, the complexity of applying. So there was a balance to be had. But you're right, Sue, in your reading, there will be a robust conversation with the visitors by the peer support worker. And we're definitely not supporting or not supportive of people who can make their own way by usual transport means, they've got their own car. and therefore it is a negotiated position to be gatekept by Notts Healthcare, which is why I think it's even more important that we have a shared financial risk around this as well, so that they are aware of their own financial risks if this does blossom, shall we say. Yeah.
Is it the sort of thing that might benefit from a review after a year if we find take-up is materially higher than the 25% that you've based your assumptions on?
Yeah, I think that would be a reasonable time frame for review, Sue.
Thanks.
Thanks. DT, your hand was up and has now gone down. Have your points been raised?
Yeah, I think sort of, yeah, it's been raised, but I think Sue has a very valid point, really. I think as much as it's important, I think it would come into challenge by other people who need it as much.
Thank you, DT. Thanks, Sue, and thank you for your presentation, Victoria, and answering all the questions that have been flung at you. Going back to the recommendations, shall we go through it step by step? First one is consider, which we have done, and approve the proposal to establish a Bassetlaw travel plan for visitors with mental health inpatients. Are we happy to approve? If we are, keep your hand down. If we're unhappy to approve, please raise your hand. Okay, approved. Approve the proposal to review the travel plan in 2 years. I think we've said we're going to review it in 1 year. Again, if we're happy to approve, hands down. Unhappy, hands up. We've noted the potential financial risk, which again is why we're going to review it after a year. So we've approved an earlier review. That's okay. Provide a final decision with respect to the proposed relocation of specialist mental health inpatient beds from Bassetlaw Hospital to Millbrook and Sherwood Oaks. Are we happy to approve the relocation? Again, hands down if we're happy, hands up if we're not happy. Okay, are you happy with that, Idris and Victoria? Is there anything I've missed out there that you want me to recover?
No,
thank you very much.
Okay, brilliant. Thank you. We can take a breath now. I think we've got one item of any other business on the public section. Is that right? Oh, sorry, Kathy.
I'm just wondering, Idris, and Eric, whether you would want me to stay or shall I go now?
Well, I think we've got one other any other business on the public in it, and then you can go after that. If that's all right. Kathy.
Okay, thank you.
Just so we have input from our extensive nursing team. It's always good having input if Nicola's not present.
Okay, thank you.
Thank you.
Hi, Eric. If it's Sam, it needs to go into confidential. My
point.
No,
it wasn't you,
okay.
Sam. I got that email. It was one that Lindsay had sent. Just get my emails back up. Which is the ICB development update, Idris. Is that correct?
Yes, that's right, Eric. And this is really for information. It's just been made available, and each governing body across South Yorkshire and Bassetlaw is receiving it in public. Obviously, it goes into some detail in terms of the development both regionally and nationally. I don't intend to go through the detail of it, though, because from our perspective, obviously, the updates on the Nottingham and Nottinghamshire ICB is more relevant than the South Yorkshire one. But I just wanted to make sure that you had sight of the same information that was going to the 4 governing bodies that will remain in the South Yorkshire Integrated Care Board when that's established from the 1st of April next year. And it's not for decision, really. It is an update, so it's a factual document that covers, I think, quite a number of areas. And there is parallel work going on from a Nottinghamshire perspective, and we'll cover that in a separate meeting in much more detail.
Thank you very much, Idris. I assume that as it's for information, there'll be no questions on this. I haven't been informed of any other business, but I'll just do a quick look around and see if there is any other business. No, so I shall draw the public meeting to a close. It says 10:32 on my screen. Shall we come back for 10:40? Give people a chance to get a cup of tea, comfort break, etc. So 10:40, guys. And Kathy, thank you for joining us on Nicola's behalf this morning.
You're welcome. Thank you.